The screen appears how it appears on the roster. We still have about 25 seconds before we officially get started. Okay, so we will call it official start time. Again, good evening to everyone. Just to make sure everyone remembered, place your name and campus in the chat. So your name, your first and last name, and the campus in the chat. Next, make sure, look at your name on the screen and ensure that it matches how it appears on the roster. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrator. Make sure that you remain in the camera's view for the entirety unless you're on break or you send a message in the chat to myself saying that you are going away from the camera for whatever reason. Put it in the chat and make sure you send it to myself. So hopefully you've had a good week. Everyone now, they tell us that classes are finalized, so everyone is where they're going to be for the rest of the term. So we will go ahead and get started here. So let's just look back and let's just have a few moments discussing and remembering last week's information. So in the chat, you do utilize different ways to verify your understanding. So in the chat, take your time. When I say the word prioritization, to put these into priority, either define what that means and also what helps you determine what priority is. So the word prioritization, that's a big term. There's a lot of moving parts to it. So in the chat, take your time and you send it out to everyone. We'll give you about 2.5 minutes to type that. So prioritization, what helps you to determine what that is and what things do you think about? Put it into your own terms. How do you understand? What's your understanding? I'm looking for my clock, y'all. So you still have the 2.5 minutes. I have found my little clock here. So prioritization. We are discussing prioritization. What is that? And what helps you to determine what to do first, next, and so on? So in the chat and send it out to everyone. Putting the 2.5 minutes on. Again, make sure you place your name and your campus in the chat. Ensure that you remain in front of the camera for the entirety, unless we are off camera. Also, remember that these sessions are recorded and they are viewed by the attendance administrator. So what we are talking about now, you should see the messages coming in, but still just think back before looking at your classmates' responses. Put it into your own words. What is prioritization? What helps you to determine what priority is? We have 5 patients. Patients in room 201, 202, 203, 204, and 205. What are we going to do first? Second, third, and so forth. Prioritization. What is that? What helps you to determine what is priority? Let me start looking and reading some of the responses and send it out so everyone can see the responses. You still have 1 minute, 34 seconds. So I'll wait before I start reading. 1 minute. 41 seconds. Prioritization. What is it? What helps you determine what is priority? All right. We're going to look at your responses here. I want to put ABCs, S bar. So S bar is that tool that helps us to communicate, so that when we are communicating a change in our client, so that we can give that information in a detailed, formatted, structured way. So notifying the healthcare provider of a change in a person's status is a priority. And someone mentioned ABC. Respiratory, we know airway, breathing, circulation. If something is going on with that patient, there's a change. And we do want to, if it's a change in their respirations, the O2 saturation, they're having trouble completing sentences, they're using their accessory muscles. Think about if we have to do that focused respiratory assessment. Notify that doctor of that change and think about those things that have to do with airway, breathing, and circulation. Is that client head already, has the bed already elevated? Is that client already on oxygen? Do we see that nasal flare? Okay. And then, so if we have clients that are, if we have a unlicensed personnel on our team, initially that client was stable, but now that client is no longer stable because we just said, we've noticed a change. It could be the respiratory status, it could be the mental status. And if it's respiratory, we're going to do that focused, detailed respiratory assessment. So we are checking all things respiratory, O2 sat, respirations. We're asking them questions to see if they can complete them without interruption. Because if a person is having a hard time at moving air, then they won't be able to answer completely. They'll have to stop and gasp for breath. So going back to the question, if initially we had an unlicensed personnel assigned to that patient, should we allow that unlicensed personnel to remain assigned to that patient? Or should we reassign them to someone else? You can come off mute and just say yes or no, or you can put yes or no in the chat.
Reassign them to someone else.
Okay, good, because remember, with delegating, delegation includes patients that are stable. So in the event that patient status is changed, if you just say status change, respiratory, mental status change, we're notifying that doctor. We've done that focused, detailed assessment of the ABCs. We need to reassign that patient. So all of those are things you as that leader in that long-term nursing facility, things are fluid. So if something changes right now, then we have to think through all of those things, including reassigning that patient to taking that task away, removing that delegation from that unlicensed person. Okay. So as I mentioned, doing that detailed respiratory assessment, you mentioned ABC, think about what things do we measure or do we assess? What information do we gather to determine whether or not the ABCs are normal or abnormal? We're asking those questions. We're trying to measure orientation, and we compare it with what we got the last time we were in with the client, or with the information that our outgoing nurse information that they gave us. We make that comparison to see if there's really a change. Okay, so let me read a few more responses here. So I'm going to give you another scenario. So remember I mentioned we had all those patients, and we're trying to see, we're talking about prioritization. What things should we do first, second? There's some things that we can do like simultaneous, like we just said, we reassign the client, we notify the physician, but before that, we've gotten that detailed assessment. Helping patients who need the help the fastest. Okay, that's a good point. So a patient in room 201, let me give you some scenarios and we see which way we're going with that point. Patient in room 201, they are hypertensive patient and the orders, they check their blood pressure prior to lunch. And matter of fact, we're checking their blood pressure 3 times a day before every meal. The next patient in the next room says their orders indicate that we need to check their glucose before each meal. The next patient, they are scheduled some medication before lunch. And then the next patient is they're ringing out because they need some type of assistance to change the position in the bed. They want to be repositioned. They might even be calling out because they have to use the restroom. Okay. So of those patients, which one is priority? Looking at your classmates, your teammates' responses, and we're still talking about prioritization. We're just applying what we know to a situation. We had a 4 patients. Which one is going to be priority? It's saying glucose check. Did someone say, so I'm only seeing glucose checks? Is that what we all agreeing to? Don't be afraid. It's just stay safe. If you disagree, put your response in the chat or come off mute. So we got 4 patients. You remember what the patients were. We got one that's supposed to get blood pressure checked before meal, one to get the glucose checked before meal. What did I say? The other one was person needed something. They were on the line. They needed position change. They may have needed to use the restroom. And the other person, oh, they had a scheduled medication. Let's see. Who said that? Michaela, am I saying your name correct? Michaela McCoy. Read your response for prioritization. Did I
I
have
put helping patients who needs help the fastest.
Nicola, read what you put in the chat regarding prioritization. Am I saying your name correct, Rochester? What did you say? Brenda, come off mute and tell me, read what you put for prioritization.
Oh, sorry. I thought you said Nicole. It's the level of need of each patient, acute versus chronic.
Okay. And then Brenda. One more Brenda read for us. What did you put in the chat?
I put like the urgency, whatever is urgent. You have to assess who needs attention first.
Okay. So I want everyone, and not to say that your responses were not correct, but I want you to listen to what they just said and look in the chat.
So would it be the assistant, the patient, or like if they had to go to the bathroom?
Following, yes, Ms. Thomas, say that again.
Assisting the patient, like with positioning or going to the restroom.
Exactly, because what did the other patients have in common? They were all
scheduled. I mean, like
scheduled. It was chronic. It was not acute. Is what Ms. Artesta put. Cora said helping the patient who needs help the fastest. The other ones, they were just, is that my no, that's someone else's timer, I think. The patient that needs to go to the restroom or needs to be repositioned, they needed something right then. Everything else was scheduled. So take what you know about prioritization. Your examples, your definitions that you placed in there were correct. Now we need to apply them to situations. Are there any questions about the scenarios that I called out as why we selected the patient that needed to be repositioned or they need to go to the restroom, why that person should have been first?
Dr. Morton,
Mm-hmm.
Could you give the rationale or just explain why the medication wouldn't be first?
Because those things were not they were not acute. It wasn't urgent. Those things were scheduled. Remember, I said that it was just a normal. I didn't say normal because we don't use that. We don't like to use that word. It was just a blood pressure check before meals. It was just a glucose check before meals. Now, I added in that the patient was the one that needs the glucose check that they had a change in mental status or skin was cool and clammy, then
Okay.
that changes the urgency. That's something acute. That's not just chronic. That's not expected. And we'll give you some words to think about as we look at this PowerPoint. But yes, so your definitions that you all gave, they were spot on, but now you need to apply them to different situations. Again, the patient that had the routine blood pressure check. Now, had they been complaining of headache, they had visual changes, and that would have been different. Person would have been urgent. But this patient just had blood pressure check prior to their meal. And sometimes that will be the order, measuring someone's blood pressure in different positions, sitting, lying, especially if they're trying to see if they have orthostatic hypertension, to see if they are even trying to get that person a diagnosis of hypertension. So they'll monitor them. But these patients, usually when they do that, they're stable. They're unstable, stable, but they're more stable comparing to someone that needs to go to the restroom or they're needing a position change because, they're hurting. That's more urgent. So, and then think about when we're trying to think about priority too, I think someone did put in there, if we can prevent some type of injury, this client is ringing the bell and they're needing to go to the restroom or they're needing a position change and then they need assistance. So if we don't provide that assistance for them and they try to do it themselves, more than likely they're going to injure themselves. So that helps us too to decide priorities. But things that are scheduled, and so that, we're going to take care of all of our patients, but go back to our key concept, which was prioritization, which things should have been a priority. Now, even if our client had a dressing change, just a routine dressing change, versus the CNA went in or the unlicensed personnel went in and they report to you that the dressing was soiled, with bright red blood. That's different than just a routine dressing change. Okay. Any questions on prioritization? So anytime that a pain is safety. So we want to, of course, reassess clients' pain levels, especially if we administer medication and it's based on, those subjective findings, they're stating, or objective findings. We are observing moaning, crying, and facial grimaces. We do want to go back and reassess and determine whether or not that client, has that pain gotten any better, or is it actually worse? Okay. All right, let me give you just some more. Let's focus a little bit more on, which is still prioritization, decision making. Okay, so we do want to make sure that our focus is on safety, keeping those clients free from falls and injuries. And injury also includes, when we're going in doing those skills, for example, inserting a Foley catheter, it is an honor system. We know that's a sterile procedure. In the event that sterility is broken, no one's there to be able to tell you, hey, you broke sterility, get a new kit. It's on you as that nurse to make that decision to keep that client safe and to go get that new kit. So we have to be aware, noticing things, our awareness to, those changes, those cues and patterns. So that's why it's important, at a minimum, we go in and assess our clients every 2 hours. It doesn't mean that only every 2 hours we're going to assess, to interact with our patients at a minimum. Because and it's important that we get that report. Now, everyone is training to that bedside report. The oncoming nurse is coming on, the outgoing nurse is going home, and we're at bedside giving that information so we can look at that client. And what that helps us to do is notice and be aware of those changes, because sometimes changes are not huge changes, they're small little changes. So you will identify those cues and patterns of when a patient has changed. initially they were talking, they were communicating to us, responding appropriately and readily. And then the next time we go in, the client is still alert, but they're withdrawn, they're not saying as much. So being aware and noticing those changes, identifying those cues and patterns is a signal to us that something has changed with our client, that their status has changed. And they can still be stable, but we do need to make note of those changes. I know you all probably have heard of sundowners, like the client is one way, prior to lunch, and then after lunch, as the sun starts to go down, the behavior of that client starts to change. It's like almost like a different person. But it's important that we notice those changes. Those changes are documented. And then if it warrants, if it's acute, then of course, we are notifying that healthcare provider. We do want to always reflect on that patient's specific needs, because that's going to indicate whether or not that care plan needs to be adjusted. So remember that care plan is that roadmap, is our way, it's our recipe to take care of that patient in room 201, that patient that's in room 202. Even if both clients have hypertension, each client will still have their own care plan specifically to address whatever it is that they have, their needs are regarding hypertension or whatever that disease process is. And we want to be mindful of what that client's specific needs are, that individualized care, specific needs, all those things mean the same, those terms mean the same thing. And then we should be adjusting, the care plan will be adjusted based on what that client needs are. Because remember that last column of the care plan, we're evaluating, and the RN and the LPN, we're together talking, well, this goal was met, this goal was not met, and we're trying to figure out, what is there a different intervention that needs to be implemented? And so nevertheless, evidence-based protocols guide what we do. But our clinical judgment, those small cues indicating, that those changes in our client, it helps us to determine what this client specifically needs so we can provide that individual care, and so that care plan is adjusted accordingly. Okay? So let's go back, and we're still talking about priority, and we're reviewing. And let's see, let me give you another patient. Patient in room 201 again. So that patient was alert talking to us when we went in at 10 a.m. Alert talking to us, vital signs were within normal limits. Blood pressure was, 122 over 74, respirations were 18. And so let me change up the patient. So the patient's in room 201, but this patient has just come back from having some type of procedure done. They could have had surgery, they could be post-op, it could be they went down and had an MRI with contrast. Prior to that, the patient was alert oriented talking to us, and then those were the vital signs. And then at 10 o'clock, we went into to assess the client, just to check in on them. We noticed that their mental status had changed. We noticed that their blood pressure had dropped or either increased significantly. So it was either really high or it was really low. We did notice that the mental status had changed. They were lethargic. What do we do first? What's the best action? Right? And think about the concept is prioritization. Put it into context. Put it into context. What did I say this patient had just had done to them? They had a procedure where they had received some medication, like MRI with contrast, where they had just come back from surgery. So this is not just a regular patient, so to speak. So put it into context is what so I want you to start forming and shaping your thinking of which way we should go. So what's our best action first? What should we be doing? What should we do? So let me hear from 3 people. What should we do? Can I give you the scenario again?
Take their vitals.
Okay. Check vital. What else we have?
I'm sorry, can you do the vital signs again?
Okay, so what
I mean, that's
we do have the vital signs. I'm sorry, we did check the vital signs. So okay, so initially before going to have the procedure done, whether or not it was MRI with contrast or surgery, the vital signs are 120/80. Now the blood pressure is significantly high, meaning it's above. We'll just say it's 190/101. The respirations are, or the blood pressure is 60/40. Either way, the blood pressure is significantly out of range. What should we do? So are you saying reassess the vital signs? What should we do?
The medications, and if it was a surgery, then check the surgical site.
Check the surgical side, okay?
And see if they were what medication they were given while they were gone.
Okay. Is the blood pressure significantly higher or significantly lower? There's a change in the patient's mental status. Patient was alert oriented. This person now is drowsy, hard to arouse.
I would assess the breathing.
Okay, so vital signs, all vital signs are out of range. So what do we do then?
Contact the provider.
Got it. So that's going to be because we already had our baseline. Our baseline, this person was alert talking to us, and they were fine. They went and had some procedure, whether it was surgery, they had the MRI that had contrast in it. And so we've established our baseline when we initially went in. We got our oncoming report, we established our baseline. After this procedure, we noticed this huge change. Vital signs are out of range, all of them, either high or low. Patient's mental status is altered. They're not responding to us appropriately. So we verified because we know this person is alert or talking to us, responding readily. Now this person's drowsy. Blood pressure sky high or either really, really low. Respirations are high or really, really slow. Either way, they're out of range. So we want to go ahead and call that healthcare provider. Okay. All right. So let's move on here. So that's the type of if you think about when you go to clinicals, you get your patients, you assign your patients, they have all these diagnoses and you have to collaborate with the RN and you're deciding, what the top 3 NANDAs and all of that. So that's what we're doing. So kind of think like that because that's going to be the next gen questions. This is going to be your NCLEX questions. These are your, exam type questions. So, but you have to have that foundation. Even if you have to go back, even in those scenarios that I gave, and you have to go back and say, well, respiration, why respiration is important? Well, what body system is the respirations belong to? Well, that's the respiratory system. Well, what does my respiratory system do for me? Well, this gas is fine. So if the gas is not, those gases are, we're not expelling carbon dioxide like we're supposed to, the inhaling oxygen like we're supposed to, then the person's breathing is going to speed up because they're trying to get, that appropriate gas exchange to take place. Well, what organs, the lungs, well, these things are not taking place. What can happen to this person? So this should be your thought process, even if you have to go all the way back to the body system. But make sure that you understand what prioritization is, what helps you determine what first, second, and third. And you all gave some really good descriptions in the chat. Okay, looking in the chat here. And someone said something about medication. Yes, that's why I said the MRI had contrast because people could have eaten strawberries all their life, but then today could have had contrast several MRIs prior to today, but then today they got that MRI and that contrast, and they were having a response to it. But they were coming from surgery and they had pain medication. Sometimes it's too much for them. Sometimes it's an allergic reaction. So that was a good point about thinking about, well, hey, what medications does this person have? Do you go get the Narcan? Looking at that surgical site. But we do need to is it better, Heather? My pencil was there. Maybe that's what it was. we do need to consider that, but we need to go ahead and notify that healthcare provider. Okay. All right, so let's go on in and go to our new content here. And then we're gonna wrap it all up. Are you all able to hear me better now? My pencil was there. I don't know if that had anything to do with it. Mm. So let's look at this ethics. And then the law. Let's see, that's something. Okay, is it better now? Okay. All right, good. Thank you for letting me know that. I'm not sure. I just turned my volume down and turned it back up. You never know with these things. Okay. Oh, no, thank you. I want you to be able to hear what I'm saying. It's not going to be do us any good if you're not hearing. Good. I did have my pencil laying there, so I don't know. Okay, so let's get to moving here. So what we're gonna do is talk about ethics in the law, and then I will give some examples, and then we'll go back and cover all of our material that we went over last week and this week. And then we'll put you into your groups, and then we will let you all discuss. So, of course, we're here for the 2 hours. Forget how many minutes, but anyway, so that's our agenda for tonight. Again, if you have not placed your name in campus in the chat, please do so. As a reminder, these sessions are recorded and they are viewed by the attendance administrators. Just as a reminder, make sure that you're in that appropriate place, making sure, remember all those places that you can't be in. So let's move forward. Okay. Okay, so here we go. Ethics is a system of standards or moral principles that directs actions as being right or wrong. Ethics is concerned with ways people either individually or as a group decide the following: right or wrong, if one has the right to do something. Think about autonomy. Those clients, they have the right to choose. We make sure that they have enough information so that they can make that informed decision. But if they choose not to go forth with the intervention, if they refuse the medication, they refuse the chemo, if they refuse the surgery, they have a right to. And we support them in that. We don't not take care of them because, they're choosing not to take part in an intervention. And if one has the duty to do something. So we do encourage for us to work as teams, with our coworkers. But when we do that, we want to make sure when we're assisting our coworkers that we're not assuming duty for their patients. So when we ask and encourage team members to work as coworkers, do things without being asked, we're talking about maybe help restocking their medication cart, emptying their trash, or refreshing their water or their juice container. We're not talking about assuming duty for clients or patients that you are not assigned to. So ethics, is this right or wrong? Is this the correct thing to do or not? Now, our Nurses Practice Act, from whatever state that you're in or that you're licensed in, is our to-do list. These are things that we can lawfully do. It is okay to do these things. But that does not mean that you will have coworkers that will ask you to do things that they know that you're not supposed to do. That's outside of your scope of practice. That the Nurse Practice Act says that you cannot do. The Nurse State Practice Act, the facilities, policies, and procedures, all of those things match. So a facility should not have you performing any tasks that the Nurse Practice Act has not laid out and say, hey, yes, it is lawful for this nurse to do this in this setting. So policy as the Nurse Practice Acts are revised and changed up a little bit, so are the facilities, policies, and procedures. So when someone called 1-800-lawyer, that's what they go back to. They go back to, what did your nurses, your state's Nurse Practice Act, what did it say this nurse could lawfully do in this state? Then they look at that facility's policies and procedures. They both should be matching, because that facility should not be asking you to do anything that's outside of your scope, that is not listed on this state Nurses Practice Act. Okay. This slide talks about personal and professional ethics. Personally, I think away, and professionally, you think away. So going back to what this state Nurses Practice Act, remember I said it's the things, the tasks that you can lawfully perform. It is okay, because the state Nurse Practice Act says I can do these things lawfully. But personally, the nurse, might have an issue or a concern where whatever it is that my state Nurse Practice Act says I can do, I may have a problem with it. I may think personally, oh, I don't want to perform that task. So as you go out and be thinking about the different settings that you might want to work in, as you think about, we'll talk about interviews and different settings, you want to ask those questions. You want to know, what task in that facility will you be responsible for? Because there might be some tasks that you might not want to take part in, because personally, you think that that is not the right thing to do as a nurse. But lawfully, professionally, ethically, you can't. So personal ethics provides personal guidelines for living. Is what each person thinks individually, their personal thoughts about it. Ultimately, we choose. But then, like I said, sometimes our personal ethics conflicts, bump heads, disagrees with what professionally or lawfully I can do in a setting. Okay, let's talk about this Western secular belief system. Okay, individual autonomy means self-rule. Individuals, they have that capacity to make decisions, to think through, to decide freely. They have the freedom to choose. I want this medication, or I don't want that medication. You can see that this person's hurting. They have facial grimace, and they're rating their pain as a 6 out of 10. But that patient chooses. They self-rule. I don't want that medication. I'll just push through. That person has the right to refuse. Individual rights means the ability to assert one's rights. To the extent to which a client can exert his or her rights is restricted. Their rights cannot restrict the rights of others. So while a person, has the freedom to, to make a choice, but it cannot inflict on or infringe on someone else's rights as well. So it has to be a nice little balance. So the person has the right to refuse, but then they can't be calling 1-800-lawyer saying, well, hey, the nurse didn't administer my medication. That's why it's so important to document. That client was offered, refused, you want to document that. So the right to consent to care, right to choose between alternative treatments. They can say, well, hey, instead of this pain medication, ask the doctor, can I, what else is there? Can I get a massage? Can I get a back rub? Can therapy work with me when my leg starts to hurt? Can restorative, what other treatments are there besides this medication, besides this chemotherapy? And the client has a right to consent. That means, hey, I accept this treatment. I'll take this medication, put my arm out, go ahead and draw this blood, or I have the right to refuse that treatment. No, I don't want my blood drawn for my CBC. And then women's rights over their own bodies. So these are some things that we have to consider. Ethical responsibilities, we have that responsibility. We're advocating for that client. If that client wants to know alternative treatments, we let that healthcare provider know. But hey, they're wanting what's some alternative treatments. They're wanting a second opinion. We advocate for that client. And then even if we have to call upon the other healthcare team members, for example, if the client has dietary restrictions on, based on their preference, we bring that dietitian in. We ensure that that dietitian comes in and have that discussion with that patient and decide what other food options, what other meal options can be offered to this client. Okay. So colleague reporting. Let me give you an example. Let's see. We have you notice you're coming on shift, the nurse, you've gotten a report. The nurse has told you that the client in room 201, I'm picking on the patient in room 201, they requested pain medication for their left arm hurt. And you go on in and you do your HITSO assessment. And then, we follow up. We also check their pain. And so in the midst of our conversation, say, well, hey, I want to check your pain anyways. But, we're just trying to determine whether or not the medicine that you received at, we'll just say 215, did it do any good? And that client says, well, I understand that you're checking my pain, but I didn't receive any medicine at 215. What if you notice that the outgoing nurse told you they administered the client's medications, and while you were restocking your cart, you noticed that the vial was still there unopened? What do you do in both instances? What do we do?
You report it.
Report it to our supervisor. Exactly. Yeah, there are times when you will have to, so you want to be mindful of all these moving parts. As that leader, as you advocating for that client's, in that client's best interest, you want to be thinking of, you got to just keep your eyes and ears open for everything. Because remember, they're establishing that baseline. They're going home. So things that you're telling them, you're going to follow up on it also. And then you're going to establish your own baseline and compare it to what they have told you. If you went in the client and saying, well, hey, I didn't get any medicine at 215. I understand you need to assess my pain, but I didn't receive any medicine. Now that client could be telling the truth or not, but then we did see that the medication vial, specifically the medicine that this client was supposed to be receiving, was still on the cart or at the desk unopened where that nurse was sitting. We don't know, but we do need to report that so that, things can be looked into. Okay, so these principles, we have non-malfeasance, doing no harm, benefiting is what we're doing, benefiting this client. So we want to make sure that, we always say beds in lowest position, call lights in reach, things are in reach. We want to, assess pain. We want to be thinking about, are there any things in the client's environment that could cause them any harm? We want to be thinking about these things. Autonomy. Client has the right to choose, to refuse. Role of privacy and autonomy. Privacy is both a legal and an ethical issue. It falls under, both topics. That privacy. The clients can be in the hospital, but they have the right not to be listed on that roster as being there. They have the right for their family members not to visit them. So they have that right to, things being private. And ethically, we have to abide by their wishes. As long as it's not causing us putting us in any danger and them in any danger, then we abide by it. Fidelity, we want to be true to our clients. If we're saying we'll be back in an hour, or get that water pitcher, I'll bring you some ice right back. We don't return until 2 hours. If we're saying that we will be right back and we're going to go get that ice, even if we can delegate that task to someone else, or ask one of our coworkers, a fellow nurse, say, hey, this has come up. Are you able to get that ice and take it back to that patient in that room? Because remember, we want to establish those therapeutic relationships up front. We're not changing the rules. We're not breaking rules, but those things that we're saying that we're going to do, we need to follow through with them.
And when we can't, see if there's an alternate way that we can address that, it can be delegated, or we can ask one of our coworkers, counterparts to fulfill the task. We don't want them to do anything that they're going to assume duty though. And then we want to treat all of our patients fair. I know a lot of times in the emergency room, there are sometimes patients that will come when they run out of medications. That's a safe place for them. They know that they don't have to worry about pay status. It's okay. We take care. They come in there the 10th of every month. Oh, well, they come in. We still provide that best care for that client, fair to all of our clients. If a client has a substance abuse problem, it doesn't matter. We still provide that best care for our clients. The client has just lost their job. They don't have their insurance, and we ask for the insurance pay status. We don't turn them away. We still provide that best care for our clients. Now we talk about autonomy, supporting the client's decisions. Now listen up now, beneficent paternalism. It is usually used this the opposite of autonomy, but it's only usually used in emergency situations. Okay. So what happens usually in this instance, the parent or guardian, they've made a decision about the patient's care. There's been a decision made about the client's care. The healthcare provider has also made a decision about the client's care, and usually they're not the same. So the parent or guardian says, we want treatment option A. The healthcare provider says, treatment option B would be best. I know this would be the best option. They go back in, they have the conversations with the parent or guardian. Parent or guardian they don't change their mind about the decision that they've made. We're going to stick with choice A. So with beneficent paternalism, that healthcare provider, because they think that it is what is best for that client, they can obtain a court order for that information to be presented to the courts, which goes against what the parents or guardians' wishes are. It does not mean that the courts will go with the healthcare provider, option B. Does not mean that. But beneficent paternalism gives that healthcare provider, it's only used in emergency situations, the opportunity to provide information to someone else besides the parent or guardians. And I can't think of a case right now that, is widely known. It'll come to me where, this right here, because I said, you don't hear about it often, but it is a thing. Beneficent paternalism. It's a disrespectful attitude toward the client and what the client has to contribute to their personal care and recovery. It's going against whatever that client has decided they want to do. So it's like the healthcare provider has, I know what's best for you attitude. So I'm just going to disregard what you think is best. Let me call up the courts, petition the courts, follow whatever that procedure is. So my decision information can be heard by the courts. And hopefully they will, side with the healthcare provider. That's what their hopes are. Because true, it's not that the healthcare provider is just outright trying to go against the parent or guardian, but they really do based on the evidence, their experience, and they just think that that's the better decision. You run into this, I'm gonna make it real, not as complex. A lot of times, patients have that do not resuscitate order. In addition to that, they may have it written specifically in the event that I need IV fluids or medication, do not administer those to me. And so that client in room 201 has a situation where, if we could just get this IV started on this client and get them that one bag of fluids, I know that they'll be rehydrated. But that DNR, those orders, that legal document that says do not resuscitate, do not administer those IV fluids or medication, those are legal documents. Even though the evidence shows that this might be the better option to give them an IV and let those fluids go, we can't because that document is there. So that's an example of where beneficent paternalism, where that healthcare provider would say, no, I want to override this. This child can live a healthy life if this parent or guardian just will allow us to administer this medication or do whatever the treatment option is. I hope that I made that a little bit more clear for you. So these legal terms, we'll go in more detail in these terms here as we go along. But just to make sure that we know of them. And at the other slide, the other PowerPoint, we have them all individual listed. So, but just think about this informed consent. You know, what is when someone gives permission, you know, do they have all the information? Have they truly given us permission to do whatever that procedure is on them? If they're still asking, who would do my surgery? You know, are there any alternatives? Well, I know Dr. Bone is going to do my surgery, but I understand there's a different doctor that's going to put me to sleep, but I don't know what their name is. So if that patient is still having those questions, have they really given consent? Well, they told me they was going to go in and do surgery, but I'm not sure what's my recovery time. I'm not sure what's going to happen after the surgery. Do I need to go to the skilled nursing facility, or will I be discharged back home, you know, in a day or so? If the patients are having those type questions, have they really received enough information on their level that they can understand? Because if they have, they wouldn't have those questions. So we have to make sure. So if your clients are saying, you know, hey nurse, you know, the doctor told me, Dr. Bone said he's doing my surgery, but I don't know who's putting me to sleep. You're gonna have to make that phone call. Hey, this person, you know, they don't know who's, you know, is gonna actually put them to sleep, provide the anesthesia for them. We need somebody to come back in and talk to them. That we're being that client advocate. So we talked about the Nurse Practice Act. It's specific by state. The State Nurse Practice Act. So we do have multi-state licenses. So, but you still want to make sure that whatever state that you're practicing in, that you're following that state scope of practice. So in the event that they call $1-800 lawyer, the lawyer bring this nurse expert in to look at the Nurse Practice Act for that state, the facilities policies and procedures, and they look at what you documented, and those things don't all mesh. What you documented is things that are outside of your scope for that state. And the nurse says, well, hey, I didn't realize. Ignorance of the nurse of that state's Nurse Practice Act is never a defense in defending the nurse. You know, we have to know. So once you, there are some tasks and things that are listed on our scope of practice that are similar for each state, but you still need to know, for those of you that will be doing the multi-state, when you're in that state, follow that state's guidelines, and you'll get all of that once you get your whatever you decide, single state or multi-state. You'll have access to all of that. And matter of fact, you can look that up on before you even become a nurse, but they specifically give you the links and everything to those nurse practice acts for each state, because it is our responsibility to make sure that's what we're doing. So let's talk about the functions of the State Board of Nursing. So this is a board, it's a group of people that this governing body. And so what do they do? And you may be actually, most state boards have different levels of nurses on their board. But as a person being on that board, what are the things that they oversee? They oversee the licensure process, the fees. In the event that someone's license are suspended or revoked, they're involved with that, trying to get that person back on track, coming up with that plan to get that person's license back reinstated. They're also involved with those paired professional programs. All states have them. In the event that a nurse has a problem with substance abuse, they have these programs. So that state board, they oversee and they assist with these different type functions. Continuing education, they come up with opportunity. A lot of times each state has on the board website, they have these continuing education programs that you can view free of charge. but they bring out whatever the latest programs that provide the latest evidence. So they replace the old ones, because remember, when you're doing your papers and things, you want to use within the last 5 years. So they refresh those continuing education components that you will have access to as a nurse in that state. Once you'll get your own login, and that information will be there. But this board oversees a lot. They have a lot of interactions. And like I said, it's usually not a full-time position, but this is something that you can do in whatever state that you're in. You can participate in that on that board. Now, a lot of times I think there's a voting process, and all of that. Sometimes the states governors, sometimes they appoint people to these boards, but nevertheless is a assembly of people that are overseeing these different parts. The fees, the licensure process. If someone has unprofessional conduct, what happens? This is a license suspended, or they revoked. They're involved with all of that. Okay, so some more common Board of Nursing actions. We just said setting those fees. Like, well, how did they come up with this fee? Well, they look at whatever they look at, but that board oversees the amount of money that we pay for different things. The educational programs, a lot of times the board, going back to that continuing education units, they will offer live programs that you can attend, usually free of charge, to get your continuing education units, because you'll need those. And there's so many hours that you'll have to have every so often in order to renew your license. So as that board, they'll provide educational opportunities so that we can, usually free of charge or for a minimum amount, and go and receive that latest evidence education on whatever that topic was. For example, they offered one not too long ago about the latest information about gerontology, taking care of the seasoned population. And they have one on infection control, the latest updates on vaccine dissemination. What was the best way to disseminate that and have programs inside of your facility. And it was specific to the setting. So they told you all about if you were in a skilled nursing facility, getting those consent signed, or if you were out and about in ambulatory care. So they made, even though the whole goal was to administer flu vaccines and pneumonia vaccines, they gave you some thoughts. So they narrowed down and gave you the best practices on how to get consent signed to administer those medications, and to provide that education, before and after for those patients that were receiving those medications. So we've been here an hour. So what we'll do is we'll pause and we will take our break, return in 5. Remember, you can turn your cameras off and this recording still plays. So make sure that you're muted and your cameras are off. We'll see you in 5. All righty, come on back. So we're talking about scope of practice and letting the state's nurse practice act guide what we do. So what if the LPN is working in urgent care, working in a hospital setting, and the RN or another nurse asks them to perform a procedure that is outside of their scope of practice? Should the LPN complete that task?
No, you tell them it's out of your scope.
Exactly. So, yes, so it's very important for you to know, those things that you can and cannot do, because that does not alleviate people from asking you to do things that they know that you're not supposed to do. Sometimes they don't know, but sometimes they do know. But it's still going to fall back on the LP and the person that performed the task. It falls back on us having the duty to know what we're supposed to do or not do lawfully. So we don't want to do anything that's going to exceed our scope of practice. So it's up to us to, know what our scope of practice is. Okay. So can a unlicensed personnel, can they obtain vital signs?
Yes.
Okay. Can an LPN administer oral medication?
Yes.
Can a LPN complete the initial assessment?
No.
No.
Can the LPN complete the admission assessment?
No.
Okay, it's no to both of those. So the words are essentially the same. The meaning behind them, when you put them in context of doing that assessment, that initial assessment or that admission assessment, they're the same. We don't do those. The RN can do that. Okay. Can a unlicensed personnel perform catheter care?
Yes.
Catheter care. Okay. Yes, they can. Okay. So what if we just said the unlicensed personnel, they can measure vital signs. They can check the blood pressure and all of that. So what if they report to us that the person's blood pressure or respirations are extremely out of range, either really, really high or really, really low?
The LPN go in there and check it their cells.
And then and then what else?
Mm.
That is good.
Document.
Go ahead.
Document.
Okay. And what else?
Look at the parameters to determine whether or not it needs to be addressed by the provider.
Got it. Okay. All right. So we want to verify those findings. We want to immediately, we're not gonna wait, because remember, the unlicensed personnel, they can measure those vital signs. Person stable, they can measure those vital signs. They come to us and the readings, we'll just say the blood pressure is extremely high or extremely low. Our next action should be to immediately go and assess that client ourselves, just to verify what those findings are. Of course, we're going in to assess them. We're writing them down. We're going to notify that healthcare provider or that supervisor, that registered nurse. Okay. Because sometimes the person can malfunction. Sometimes our equipment can malfunction. But we want to make sure, even if we initially go in and do vital signs and get an erroneous reading, we want to make sure, did I hear that correct? Are these batteries working correct on this machine? We want to verify and make sure that, that our equipment and that we are hearing what we should be hearing, what we really heard, rather. Okay. And then sometimes, you'll ask, if you check them, you may ask your coworker, hey, come in and listen to this these long sounds, or come in and check this blood pressure, just to verify, because we are going to, immediately reassess to verify, and then we notify that RN or that healthcare provider. Now, in the chat, let's utilize our chat. What is the primary purpose? What is the purpose of we've been talking about this State Nurse Practice Act over the last few minutes or so. What is the purpose of it? Put it into your own words. I've been giving you my definitions of it. I've been paraphrasing it. So, and then send a message out so everyone can see what you're saying. We'll give you a minute and 30 seconds. So in the chat, what is the purpose of this Nurse Practice Act by state? Find my little clock here. Just put on a minute and 30 seconds. So send it out so everyone can see your responses. $11 seconds left. Okay. All right. So that State Nurses Practice Act, even though we have a multi-state license, a single state license, and that's for all of the different, parts of being different titles of being a nurse, you can be multi-state or single state. But nevertheless, that State's Nurse Practice Act, it defines that legal scope of nursing practice. And as a result of that, the public is protected because remember, it tells us those things that we can lawfully do. It defines our scope of practice, those things we can do. And so therefore the public is protected because we're not out there doing things that we're not supposed to be doing, that we don't have the skill set or we haven't been validated on that we can do. To make sure everyone is qualified and practicing safely. It protects the public. It does. To regulate duties within a practicing scope. Yes. To maintain patient safety. And you all have hit it spot on. Exactly. Good, good, good. Okay. So let's do another little scenario. Here it is. We have some patients. Let me see what I want to do with these patients. And of course, we're adding in the Nurse Practice Act and then prioritization. With this example here, let's see. So of course, we're going to always take care of all of our patients. But the patient in room 201, they have a dressing change to do. The patient in room 202, they are needing to be repositioned soon. Because at a minimum, we're repositioned every 2 hours. So they're needing to be repositioned soon on their next schedule, at their next scheduled time. And then we picked up the phone, we've received some lab values from the lab. They're out of range. Or we picked up the phone and we received the chest x-ray report from radiology and it was abnormal. So which of those things are priority?
Can you repeat it?
Oh, you're gonna make me repeat it. I'm making up this stuff. So, okay, so you have 3 patients. One patient, what did I say, y'all? Needs a dressing change. They got a fresh wound on their leg, but it's not due now, but they'll need one. It's not time. We'll do it. It's due next shift. We'll put it next shift. Wound change, let's do next shift. The persons in the next room, they will need to be repositioned at the next even hour, and it's 10 a.m. now. We are sitting at the nurse's desk, and we receive is lab on the phone, and they're calling about the third patient, and they're telling us that their white blood cell count is abnormally high. Or we are sitting at the desk and we answer the phone and it's radiology. They're calling to say, hey, the chest x-ray shows they have pneumonia in the left lung. Which one of those requires us to do something right then?
Would it be the repositioning?
Why is it not the repositioning? Because what did I say about the repositioning?
It's scheduled.
Which will at the next scheduled time. Okay.
You have acute abnormal values of the lab.
Got it. Okay, good. Because we were saying right now, what's acute versus chronic, and we can use some different words. You all help me come up with some different words. What's more urgent, maybe, or what's more pressing? Because I said that the
Well, I
dressing
got
change.
confused because you said about the repositioning. You said at the even hour and it's 10 a.m. So I'm thinking you meaning like they need to be repositioned like now.
No, at the next schedule.
Okay.
And then the dressing change, the wound change was next shift. One, I said the next schedule change, the even hour would have been, noon, next shift. And then we are receiving these abnormal lab results right now. Okay. So, and several of you all may have thought, just like she did, you may have missed that part. So test taking tip. Make sure you go back and read through your answer choices to make sure that you're not adding or subtracting anything that's not written there. Make sure that you're understanding what's there. Is this now or is this in the future? What's this? Put it into context. So reread to make sure what you're reading is really what you're reading, because sometimes our hearing will go faster than what we're hearing and seeing, and it just get all, confused. But just make sure you go back and just make sure that you're reading for what's there. And then if you thought that when I said, why is it not? Then your thought, another test taking tip. Well, I know this right here. This doesn't need to be done right now. But let me read the next answer choice. Does it need to be done right now or can that wait? So that helps you to eliminate or throw out those placeholders, because really answer A and B were the same, right? Were they the same? So listen at answer A. Answer A was dressing change next shift. B was, and I'm not, saying the exact same words. B was the reposition at the next schedule change, even hour, I think is what I said. Reposition at the next even hour, which now is 10 o'clock. Really, aren't both of those saying the same thing at the next scheduled time? So look for another test taking tip. If answer choices are saying the exact same thing, then if it's not a select all that apply, both of those we could eliminate those answer choices. Is that making sense what I'm saying about that test taking tip? And if not, let me know and I can reword it, because I'm making up stuff as I go, but I don't want to make it too complex. But at the same time, I want you to kind of think through and kind of form and shape your thinking about process of elimination. So if it is not select all that apply, you can only select one answer and two of your answer choices are the exact same, which both of those answer choices were at the next scheduled time. We can't be both of them because it's not a select all that apply. So both of those are just placeholders. Okay. Let me know if it's not making it, if the connections are not coming through. I can reword it and try to make it a little bit more clear. Okay.
I understand it. It's just like what I don't know her name. She said about the reposition thing, because at first you said she has to get repositioned soon, and then you said that it was scheduled. So in my response, I put reposition lab values and dressing change. I mean, based off now that you're saying that the reposition is for the next, schedule, now it makes sense. Like, of course, you're gonna check the lab values because they're abnormal. followed by, reposition, then the dressing change.
Yeah, thank
Or
you.
if it the dressing change, then yeah.
Both of them are the same. They're at the next scheduled time.
Right.
Even though one says
Right.
next shift and the other one says at the next even hour, they're still the same.
Mm-hmm.
Got it. Good. All right, so let's go on with some more of our PowerPoint. Let me think if I want to give any more. Yeah, let's go on with the PowerPoint. And if I come up with some more examples, I'll stop and put them in there. So remember, you all, the exam is next week. You can use a dry erase board or a clear sheet protector. For the most part, people think, well, I just need that to jot down and, jot down my math and work out my math problems. But you can also use that to, of course, it has to be blank when you start back in front. And then once you finish, you got to erase it back in front. But you can use that paper, that dry erase board, that clear sheet protector to kind of organize your thoughts. So if you know about a concept and you're trying to, I just I just can't get it together. Use that. Jot down what you know about that concept on that dry erase board to help, organize your thoughts too. You can use it for that purpose as well. As long as it comes in blank and it goes out blank. Okay.
Is there a reason we can't use a piece of paper?
Because it was taken advantage of, was used for the wrong purpose.
Okay, so what about the people that don't have a whiteboard? Because I've used the piece of paper the whole entire time in this program.
No, can't
Oh, you
use
said
it.
we can't use paper?
That's correct. Can't use paper.
Is that in the syllabus or anything? Because I didn't read that.
Yeah, we went over that last in the orientation PowerPoint. But yeah, so you need to, get a dry erase board or one of those sheet clear protectors because it's made out of the same stuff that you can easily erase. You know what I'm talking about? That thing you slide a paper in. If you're on campus, you can ask maybe like what the librarian or someone for one of those clear sheet protectors. And dry erase board they cost, but that clear sheet thing that you slide paper in, you can easily get one of those markers and erase it on that as well. Yeah, I mean, unfortunately, that's what happens when things are not when they're not used for the purposes they're used for. It's a bad thing, but that's just how it is. So make sure you get your dry erase board or that, unless Dean Brown says, unless she changes it, but it was used for the wrong purpose. And I noticed I said erase it before you have to show it for the camera. That part wasn't in there either. What happened was somebody didn't erase stuff and they used it for the wrong purposes. And so here we are today. All right. So, fine. Okay. Disciplinary responsibility of the board and unprofessional conduct used for the wrong purposes. Unprofessional conduct. Cheating is what it was used for. So you can either receive a fine, you can end up with having to do jail time or be on like what they call it, doing volunteer time. So there's an array of I don't want to say penalties, but tasks that they'll actually complete in the event that there's some unprofessional conduct. And let me just go back. Let me just put a pin in this too. I always tell you, I remind you all that the recording is going. Why do we have a recording going during break time? Because somebody used it for the wrong purposes. So, anywho, so that's just the result of someone being unprofessional. So that's why I always remind you, hey, these cameras are on and they're viewed by the attendance administrators, you all. So as a result of someone's unprofessional conduct, we might be fined with having to pay out monies or doing volunteer tasks with a certain amount of time. For example, 100 hours of volunteering at the local pharmacy, 100 hours of volunteering at the local place of faith or at the school or whatever depends on what's available. The settings might change. There might actually be revocation, or the license may be suspended for a certain amount of time, or actually outright just taken, dismissed. That person license may be voluntary surrender. The nurse does not want to give up their license, but because of whatever happened, that unprofessional conduct, and based on that state law, that person's license are taken. And then you want to follow those specific guidelines based on what state you're in, even if you're multi-state licensed. Okay. So we have this right here lists some different examples of unprofessional conduct. So negligence, the nurse does not do what is a reasonable, prudent nurse would do in that similar situation. So they'll bring in the nurse expert and they'll say, hey, look at the Nurse State Practice Act, look at that facility policies and procedures, and then they'll say, hey, well, let's just see if we lined up 10 nurses and they were in the similar situation. The patient in room 201 had a mental status change, blood pressure was extremely high, extremely low. What did those 10 nurses, what were their responses? So this is what that statement means about, did the nurse do what was reasonable and prudent in a similar situation? So they'll take that in consideration. And so if, in fact, all of those nurses verified the information, called the healthcare provider, that's a reasonable response. So in the event that happened, if the nurse that's on trial and the nurse did not do that, then they would take that in consideration as being negligent, because that nurse directly put that patient in harm's way by not responding, verifying the information, and calling their healthcare provider. Okay, so incompetence examples include failure to meet generally accepted standards of nursing practice, negligence, nurses' mental disability that would interfere with the client's safety. If we have some issues going on, mental, anxiety, whatever it is, if we need to be off work or we need to go see a healthcare provider, but we push on, if we work too many hours and we push on, I'm just gonna go on in and take care of the patient, I don't want to call in, but we know that we're not physically, mentally prepared to go in and take care of those patients, and something happened, then we're at fault. If in the event, well, I forget it was in the news when, COVID first came out and they were saying that the staff were sick, and they disregarded themselves, the facility disregarded the staff being sick, therefore they made the patient sick. And so I'm sure they gathered information. Do these patients go anywhere? Did they have visitors? I'm sure they gathered all of that to determine or narrow it down to the chances of the staff actually, making their staff sick. And so in the event, like they tell you, if you don't feel well, whatever that is, that blank line, whatever it is for you, if it's important to you and you need to call in and or not be there to take care of that patient, that's what you need to do. Relieve yourself of that duty, because you'd rather do that than go in and cause harm to a patient or harm coming to you. You don't want that to happen as well. Some unethical conduct examples include a breach of the nurse's client confidentiality. You working in the emergency room, you transfer your patient up to second floor. And so we're still looking in that patient's record to see what's going on with them the next day. Well, that patient's no longer our responsibility. So we're breaching confidentiality, that privacy, because if we don't have direct care of that client, then why are we looking at that patient's record? Family members come in and say, hey, well, I just want to know, I know you took care of my loved one. Can you just go ahead and just tell me, the results of their test results? That's unethical. We don't want to do that. We will, ask the patient, if it's okay, but we just don't outright just do that on our own, because we are violating confidentiality. So alcohol and other drug abuse. Alcohol and other drug abuse by a nurse is a threat to the client's safety. The nurse has went out and, they celebrated, I don't know, whatever, and the client is under the influence of alcohol. And that nurse come on in and take care of that patient and something happens. That nurse is directly, and they're going to look back at, what happened? What happened? Was this a reasonable response? Should this have happened? Was this a reasonable response in a similar situation? They're gonna start back looking at, your social media pages, things that you posted. Well, they took a picture at, 10:59 with a wine glass. Do they really know it was wine in a glass? No, but they'll look at those things and try to put things together. Of course, you'll have to do it. The nurse will have to do a drug test, see what the alcohol level is, and then they'll go from there. Hopefully, It's just a bad outcome. Hopefully it wasn't anything on the nurse's part, but they'll look at all of that information. They'll gather all of that information, the drug test results, the blood alcohol level, to determine whether or not the nurse, the harm that came to this patient was really connected to this nurse being impaired or not. Falsifying records. So, if you didn't do it, we don't document that we did it. Okay. So let's look at these disciplinary steps of the board. The nurse is reported for stealing a client's narcotics to the State Board of Nursing. After receiving the complaint and determining that the chemical has affected the nurse's judgment, rendering them unsafe to practice, and confirming that the stolen narcotics are a violation of the Nurse Practice Act and the law, the board will review the complaint. So how do they know all of this? So you get the complaint, and they gather, of course, they got to do testing, blood or urine or hair samples or whatever it is. They look at the time clock stamps. They look at the PICSs, and they call them different things, the boxes that hold medications. They look, because everybody don't share passwords. Don't be, you think it's, well, go ahead and just log in and get that out for my patient. Don't do that. Take the time to log in for yourself, because in the event that something happens, they're going to pull all these records, the time clock, where you on your break, what time that the nurse go into the PICSs or the medication box or whatever it is that medication is in. What time was it signed out? What time was it documented on the medication administration record? All that information. Well, this nurse's drug test is negative. Their blood alcohol level is 0. So, or the opposite. And then that's how they'll put the information together. And that'll be the evidence to prove or disapprove. The board will investigate, including questioning witnesses and gathering information. So they'll ask your coworkers, hey, did you notice this? Did you notice that? They'll ask the dietary department, everyone that was on that floor, the unit secretary, to give their statements in writing. They'll look at see who worked that shift or the 3 shifts prior. It depends on what happens. They may go 3 shifts prior to the incident just to get a better picture. Then the nurse will have the opportunity to respond to the allegations during the board proceedings. This is the opportunity the nurse gives. They have the opportunity to say their part, to give their 2 cents, to speak on their behalf. Then the board action follows, the proceedings in which the disciplinary action is determined. What will be required of this nurse? Will they be let free? Will they have to pay fines and penalty? Will they do jail time? Volunteer time? What is the action that is determined for this nurse? Will they be reporting? Sometimes if the nurse is rendered impaired and they go through the impaired program, thereafter they still have to do some reporting, some checking. They have to do drug tests. And so then based on those findings, they will, keep the person working, or they may have to, suspend the license or something like that. But there's a whole process. And so there's a reason why, it's so important that you clock. You're thinking, well, why does it matter that I clock in and out? You can do it on your phone, however they want you to do, but it's so important that when they say clock out for your lunch, your break, make sure that you're doing these things. We hope that nothing ever happens. But in the event that something happens and they have to go back and gather this information to say, hey, this is what happened, then if you didn't clock out, you really did clock out, and you didn't take your break in the appropriate places or whatever, then you're gonna need extra conversations, extra statements, and everything to gather that evidence to really prove that you really were not there. That patient really was under the care of someone else at that moment in time. So follow the procedures and policies that the facilities have in place. They're there to protect you and the nurse and the patient. So we have these databases. I like to think of them as huge file cabinets that keeps all of this information in it. So we have this nurses, which is a national database. And what it does is they verify the license, the discipline actions, and the privileges of that nurse. So this site contains the nurse's license number, of course it has their name, the date of the license, when they expire, because remember these licenses, they expire after so long. And then you have to get them, renewed, and any violations. So that this is a national database. Then we have this national practitioner data bank. Prior to this huge file cabinet, if a healthcare professional had some type of disciplinary action on their record, then they were just allowed to go from place to place to place, and no one knew that. So, but I forget what year they created this thing here, but this National Practitioner Data Bank, in the event that a healthcare worker has some type of adverse actions or disciplinary actions on their record, is inside of this data bank. And so what employers, they usually do when they bring you on, they verify your license. I don't know about the, in the news we've heard about, the nurses, the imposters and stuff. I'm not sure how that happens because they usually go in. I know one nurse, they had the same name or something, but I don't know. But they supposed to go in and look at this information and verify it to see if nurse A, nurse B, and C, all the nurses have a license in that state that they're trying to practice in. That's that facility, that business, they have their own login. They look up this database. And I want to say that even nurses, CNAs, all of them have these databases where all this information is held. So that in the event that there is an imposter, that their information wouldn't be in the nurse's database because they really don't have a license. So in the event that we have someone that something has happened adversely doing their, doing them taking care of clients, and they went through that whole process and it's on their record, it will be in this data bank. And so if that client, that patient, not the patient, that nurse or that healthcare professional moved to whatever state, that facility looks into this data bank and they can see, okay, well, we know that you had this disciplinary action on your record, but right now you're cleared. But this is a data bank that they can go in and see that they actually had that information, that disciplinary action. Okay, so nursing licensures, you get that temporary permit, and in different states, it's a different amount of time. Sometimes it's 3 months, 6 months, and I'm sure you all will start those conversations if you all have not already about that temporary license, because you all are pretty much at the end of your program, and so that may be something that you want to take advantage of. It may not be, but you can. Usually, they give you that amount of time before you have to actually take your test and pass it, that you can work as that licensed nurse. Working in other states, they call it multi-states, or the states have these compacts, they have these agreements where they've looked at all of their things and they say, well, hey, and I think the largest compact is about 12 states or something like that. But anyways, it is up to you. Even if that state is in a compact, you still don't have to purchase that multi-state license. You can still purchase that single state license. And then unlicensed assistive personnel, supervision is a major concern to ensure safety of the client, because even though we delegate, we say, hey, to the unlicensed personnel, I need you to, feed the patient in room 201, need you to get their vital signs. It still does not alleviate us as that nurse being ensuring that client is safe, even though we have delegated those tasks to the unlicensed personnel. So it still does not alleviate us. We still have to follow up and ensure what the task was actually performed correctly. And then reassess that client, because that status can change. That's the example that I gave you earlier. Okay, so nursing standards of care, guideline for good nursing care, important legal implications. Based on what an ordinary prudent nurse, if you just said that, the nurse expert, they come in, they look at, and they may even bring in, you might even be a witness, bring in nurses and say, hey, this is the situation. This is the situation as what happened. What would you have done in that instance? So they'll take all that information and they'll say, well, this is what 99% of the nurses said that they would do in the similar situation. And based on the Nurse Practice Act, so this person just had a bad outcome. This patient just had a bad outcome, but it does not mean that the nurse did anything wrong. But then if they find out, well, hey, we interviewed 10 nurses and all of them said the same thing, but it didn't match up with what this nurse, which they've called the Lord, they've filed this complaint against, doesn't match their actions, then they will more than likely proceed with that litigation against that nurse. Okay. So again, I told you the Nurse Practice Act and the facilities, policies, and procedures. So if you work in an urgent care center, their policies and procedures. When you work in that skilled nursing facility, in the event that litigation or there's reported to the board, they'll go back and look at that facility's policies and procedures. They'll look at those standards for right now. Were those standards followed? Did they match? And if they did not match, that means those standards were not followed. Then that nurse is negligent. Okay, so let's look at the difference in this criminal and civil. Criminal versus civil action. So criminal, we have felonies and misdemeanors, and these includes crimes such as homicide, larceny, and embezzlement. Dealing with mismanagement or using it for the wrong purpose, doing different things with people's money that's not for the intended purpose. And then civil is individual versus the individual. Criminal is the government versus the individual. So with civil, the person had a bad outcome, even if it was unintentional. The nurse administered, the medication that was mislabeled. They were supposed to administer potassium 20 milliequivalents in one tablet, and they administered the 40 milliequivalent because the change direction sticker had fallen off the package. But it was unintentional, but it's going to go back to, well, hey, did you read the order? What did the order say? Even though that change of direction sticker fell off that medication package or bottle that alerted the nurse that there was a change in the directions, still did that nurse go back and read that order? Did the order match what the nurse actually did? It wasn't intentional, but still charges can be brought up against that nurse from the individual, even though it was unintentional. And then, because, evil does exist, sometimes people intend to cause harm to people. Hopefully we don't run into that, but it is such a thing. So in that case, still the individual can, take action against the individual. All right, so intentional torts, just a little bit more information about them. Assault and battery, causing that bodily harm. False imprisonment and use of restraints. So what are the two different kind of restraints? Well, tell me, come off mute and tell me two different kind of restraints.
I like the 4 points one, like all your 2 arms, 2 legs.
So that fall under which category? Physical restraint.
Physical.
Physical. What's the other kind of restraint? Would you say the other kind was?
Chemical.
Chemical. And what is an example of that?
Like
sedation.
Yeah.
Exactly. Medications. Well, the patient in 201, they keep ringing that call like, let me look at this MAR. So like they have some Tylenol extra strength on here. Let me go and get them some of this Tylenol extra strength. Maybe they'll go to sleep. I didn't say the patient was complaining of pain or had a fever or requested it. The nurse on their own administered that medication because they were tired of the patient ringing that bell, and they were hoping that medication would impair them, put them to sleep, alter their mental status or whatever. The patient didn't ask for it. The client's present situation did not warrant that Tylenol extra strength being administered. No fever, they not complaining of pain. We didn't assess any pain findings, but we administered in hopes that client would stop ringing that bell. That is a chemical restraint where medications are administered outside of the purpose which they were written down to be administered for. For example, I'm sure that Tylenol extra strength would have had, administer 2 tablets or 1 tablet every 4 hours for fever, or sometimes it'd be specific and say temperature above, whatever number, or it would say administer every 4 hours for complaints of pain or signs and symptoms of discomfort. But the nurse administered that medication outside of its intended use. So that's
What in the system ding it so that you can't give it? Like it'll say like it's too early to be given or something like that.
well, if it, I don't think it dings it, but it's documented. So it's now I don't know if it's one that it will ding it. Now I do know if a medication is routinely ordered, which is a different situation. Remember, I said that medication was a PRN as needed. So it is documented when you go in to administer or pull it out the cabinet or document that you gave it. And I think what you're referencing is a medication that's scheduled. What we're seeing a lot with the electronic records now, where it'll turn a different color if it's out of range. And also, if you click on it and try to administer it, a routine scheduled medicine, a message will pop up on the screen. Are you really trying to administer this medication now? Are you sure? But that's a scheduled medicine. Something that's PRN is as needed. So that block, that I don't know if that's the correct word, but whatever that keystroke doesn't prevent that person from clicking on it, and administering because it's as needed. It's not a scheduled medicine. So be careful with sharing posts and, information, talking in the elevator, walking down the hall. You all are, a lot of times in clinicals when we're talking and, talking through, trying to decide what's next and talking through a procedure. Like, for example, we were like, okay, we got a Foley catheter put in. So a couple of castmates would be together and we talk about, hey, yeah, we're going to put the Foley catheter in the patient in room 201, but let's talk through the procedure. First, we do this. So we're just talking amongst ourselves, but be aware of your voice tone when you're out, because if someone overhears you, then they know that person in room 201 needs a Foley catheter. And they look it up. Well, what's a Foley catheter? What they need that for? Then we've violated their privacy. And I meant to say sharing posts, we look at posts, but if you start sharing things, then that means you shared that information. So you put that info, then whoever shared it, put that information out there. So be careful with sharing things. You may want to just tell somebody, hey, you log on, whatever, just look at whatever on the site rather than click sharing it. Because if it's defaming or giving us false information about someone's character or them, then that's an intentional tort called defamation. Physical and emotional abuse. Oh, let me go back to this false imprisonment too. So, going back to the restraint. Well, it kind of serves as both. They used to have these, and you all probably remember what I'm talking about. Like when the children are in the little strollers that have the little wheels on them, they can move around, and once they get tired, they sit and be still. They had those things for adults. And think about it. Can that child get out of that thing? And I forget what you call little, what I'm talking about, the little thing with the little rollers on it, they push around. Can that child really get out of that thing? Unless they're overgrown for it, they really can't get out of it. So they create this same device for an adult. It was a chair with wheels on it. It had the little bar. And it was really a restraint, because if a person cannot release or open that restraint, then it's get out of it freely, then it's considered a restraint. So a lot of things that were used back in the day, so to speak, we don't use them now because they were, it's deemed as a restraint, because that person that equipment was used for, they couldn't get out of that thing freely. So, but most facilities, now those things are out. But every now and then you're running to some facilities and you'll have to step back and say, hey, is this a restraint? And you report it and say, get some understanding about what this is. Even side rails. If you're in the hospital setting and you use all 4 side rails, have you all heard this before? It's considered a restraint. Because can that person really get out of that bed freely? Is it free to get out if all 4 rails are up? And then you have the rails that are 2-sided and all that, but some facilities don't even have any rails on them at all. So, but just know chemical and physical restraints. Chemical is using that medication outside of its regular intended use. At PRN, you're administering, and it has specific guidelines that you're administering beside those guidelines. Yeah, then that's considered a chemical restraint. So those unintentional choice, something happens to the patient, they have a bad outcome, and we did all of our medication rights. We checked, we made sure that was a correct dose and amount and the appropriate route, but that patient still had a bad outcome. And so it was unintentional. So yes, the complaint will be filed. They'll still gather all that information. They'll ask and see, was this a reasonable response, by the actual nurse? And then if so, they will take that in consideration. So the penalties or the outcomes would not be as harsh, but still that patient had a bad outcome. So some common sources of malpractice, medication errors. So just like the example that I gave, where that it's just potassium, but it's still a medication. And a lot of times when a medication changes, the dose change or the directions change, they'll administer some type of sticker or some type of warning on the package to alert the nurse, even though we're supposed to be reading that order and making sure our order matches. And we have all those components of that order there, the correct dose or correct medication. Sometimes things still happen. That potassium, 40 milliequivalents, that was the original, what was in the packet. And if it's scored, we really can't have it if it's scored medication. And the order is half of it. But if we don't read the order and we administer that double dose, it really is double dosing them because now the order says 20 instead of 40, then that's a medication error. And who was that asked about the medication, won't it pull up or ding or make note of? Yes, it'll pop up on the screen, but it'll still give you the option. It'll say, do you still want to administer this medication? I think the verbiage is, this medication is outside of its normal whatever. I forget the verbiage. But if you click yes, I still want to administer it, it'll still let you go through the process of administering it. So then that's the medication error. And is considered as, malpractice. Failure to communicate. We want to make sure that we are, receiving appropriate handoff shift report and that we're giving handoff shift report. Working while impaired. I gave this example earlier. We're tired. We're sick. We worked too many hours. We went to our, we had our child's birthday party. We stayed up late trying to clean up things. We're just tired. We really don't need to go in and work. We go in. Something happens to one of our patients that we're providing care for. They'll look back and say, well, hey, this nurse was impaired, not only from substance, but also from lack of rest. So, just make sure that, we're taking care of ourselves, because if we're not taking care of, we can't take care of the patients. We need to call in off the shift. I'd rather do that than to come in and something happens to me and the patient. Failure to get informed consent. We knew the patient was asking, that they didn't know who was going to put them to sleep. They didn't know which doctor was going to do their surgery. They didn't even know what type of surgery they're going to actually do. Come on, let's go on out here and get your surgery done. Failure to get that consent. Even though those doctors, those healthcare providers come in and talk to those patients and get that consent themselves, it still falls back on us to make sure that all those questions they have are actually answered. Okay. Failure to use a medical device accurately. So make sure, if we want the example that we gave, the blood pressure cuff, what was the example? Well, if the blood pressure cuff is giving us erroneous numbers, well, we don't know if they're erroneous. Let's verify it. See if this blood pressure cuff is working properly. Because if you go back to the original packaging, those things are only made to be used so many times. But how many times have we inflated our blood pressure cuff? So those things do malfunction, or we don't know how that machine works. Hey, I need someone to, usually our facilities usually have the education person where they will, teach you how to use the device, that lets you do return demonstration and things like that. So don't try to figure it out. It's part of the process of working at that facility for knowing, being trained on how to use the different devices appropriately. And if you receive the training, you still have questions, let them know you still have questions. I think I need to go through that training again, or I need a little bit more time, because we don't want to go in and use a device incorrectly and hurt ourselves and hurt the client. And that's what end up happening. Okay. Failure to properly supervise a client. Remember, even though we're delegating to the unlicensed personnel, it still falls on us to ensure that whatever that patient is still, that task is still completed, that patient is still stable, and that we don't need to reassign. Okay, why do I need malpractice insurance? So yes, you ask a healthcare provider, you'll need in addition to your healthcare insurance and all the other insurances you have, you'll need malpractice insurance as well. The jury's award could exceed the limits of your agency's coverage. Most of the time, your facilities they have insurance, but the jury, sometimes the amount of money that they say needs to be paid to the person is more than what that facility's coverage actually is. For example, if the facility's coverage is $100,000 and the jury awards the plaintiff $200,000, where's that money going to come from? So make sure you have your insurance, and your insurance will cover that amount up to whatever that amount that that you're paying for coverage. Your employing agency could pay out an award to the plaintiff and then countersue you. So what that's saying is, they pay whatever the jury said that should be paid to that plaintiff, the person that bought the complaint, then the facility that you're working for ends up coming back and suing you. So you need that malpractice insurance. You acted outside the scope of employment, and the agency argues that it is not liable. But, the supervisor, we've been doing this thing all along. The entire time I've been working here, they've been asking us to do this, and we've been doing it every day, even though we know it was out of our scope of practice. But this one time, there was a bad outcome. So the answer is not. Remember, we talked about not knowing, and then knowing that it's out of your scope of practice and still doing a task, then that's not going to be a good failback plan. It's still going to come back on that nurse. Your employer's policy covers you only on the job. Something happens outside of that facility, outside of that building, and even though that employer, like a lot of times, this is another thing that you all, when you go to a job too, a lot of times they want a person to be like their, I don't want to say PR person, but if they have health fairs and things and you work at a facility, most of the facilities have a table at these different events, and you can be on that team of people that they clock in for work, but you go out and be at that event and hand out their literature and everything. Something happens, but that facility that you work for, the insurance only covers you inside of their building, even though they had you out there at the event, but the insurance doesn't cover outside of that brick and mortar. So all of that is to say that you need your own malpractice insurance. An agency might carry a policy that covers you only while you are employed by that institution. So if you decide, no, travel nursing is a big thing now. So make sure, even with that you have your own malpractice insurance, because that company might only cover certain facilities. It may be, or just make sure that you're covered either way. Either have your own, and if you decide to, go to different facilities, make sure that you're covered. And if you decide to work on one of those teams where you go out to do the different events and things, just make sure that insurance, hey, does this insurance cover me going out here attending this event? Ask those questions, because if something happens, we're just out there doing blood pressure screening. You just never know. Hopefully nothing happens. But if something happens, are you covered? Does that facility have you covered? So negligence, you will need to know these 4 parts of negligence. In order for you to be the nurse to be deemed negligent duty, was this patient assigned to this nurse? Was it the responsibility of this nurse to take care of this patient, to provide the services for this patient? Was there a breach? Did they have any damages? And was there approximate cost? Let me give you an example. So Nurse Lisa, had patient in room 201, 202. The care plan said that patient in room 201 required 2 persons for dressing changes. We'll just say something. Nurse Lisa said, don't worry about it, Nurse George. I got it. I got it. Nurse George said, you sure? The care plan says, we need 2 people in to do this dressing change. This won't provide this wound care. Oh yeah, I have it. So Nurse Lisa goes on in and performs the wound care. And there's some type of harm, damages, injuries that this patient receives. This proximate cause, what they're going to go back and do is say, well, hey, who was assigned this patient? What did the care plan say? 2 people needed to be in there. These damages, this injury that this person sustained, was it a direct cause because the 2 people were not in the room? If they can prove that what actually occurred went against or did not match or did not follow what the care plan said, the breach of duty, then that's the proximate cause. So if all these 4 elements are deemed can be proven, then that person is negligent. Patient's supposed to go to the shower. 2 persons assistants supposed to be in there. 2 people are supposed to assist with the shower. 2 people go into the shower room to assist. 1 person gets a phone call or they paging them overhead. Oh, I'll be back. Instead of getting someone to come in to take that person's place, that person's left in the shower with 1 person. That person falls or receives some type of injury. And they're going to say, well, hey, the injuries that this person received, is it directly related to the breach of duty, which were those things that we have said are needed to take care of this patient, which comes from the care plan. So that's negligence. So let's pause here. Let's stop and take another break. And just as a reminder, this recording still plays. You can be off camera. Just remember, be on mute. Turn your camera off. We'll see you in 5. All right, come on back. Okay, so let's check back in and let's see where we're at. Let's see here. The example that I gave earlier about, I'll give a different example. So we throw away a patient's lab sheet into the garbage can. More than likely, someone can come by and get that out of the garbage can or see that patient's information on that lab sheet. What is that a violation of?
HIPAA?
Yes. What if the family member, it could be the spouse of the patient, says, hey, you took care of my loved one today. Like, yeah. Can you just go ahead and just tell me the results of their MRI? But we have not received consent from the patient to give, that family member or any family members their information. What is that a violation of?
That's still HIPAA, right?
It's still HIPAA. We are sharing protected health information without consent. So that's the violation of HIPAA. What if, I told you all about the nurse, you'll have the opportunity, they may be already discussing that with you about, once you finish, you can work under the temporary license. But with that temporary license, it's listed as a temporary license. You can decide to or not to. So we have George, student nurse George. He's finished his formal training, and he goes to work at a urgent care, ER, some facility. But George has not completed whatever task it is to work under his temporary license. And the staff, they know it, but they knew he's graduated from school. He was an unlicensed personnel there before, and so they allow. He's no longer a student, but he's not a nurse either. They allow George to perform tasks as though he's an LPN, as though he's a nurse. What is that legal? Now he's completed the formal training. He does not have his temporary license. Does he have a scope of practice?
No.
No.
Exactly. He no longer has a scope of practice. So if he did not subscribe to the temporary license, he's no longer in school. So he's not working under the preceptor or the clinical instructor or the professor anymore. Then he doesn't have a scope of practice. And remember, the scope of practice are those things, those activities that we can lawfully perform. Okay. So let's see. So we are providing catheter care. Now we're inserting a Foley catheter on our client, and the client receives harm. They end up saying that this client ends up with a urinary tract infection. And the family, say that they call 1-800-lawyer and they look at what the standards are, and they determined that there was a failure to follow standards of care, which related to the urinary tract infection, which they're saying that is harm to that patient because that patient did not come in with urinary tract infection. As a result of that, the person had a change in mental status. They got up, they fell, they broke their hip. Is that an example of negligence? Failure to
Yeah.
follow the standards of
Yes.
care. Yes. So how would they prove that? So just think about that. Remember, it's an honor system. It's a sterile procedure. If we break sterility, it's on us to start all over again, get back to the sterile part. What facilities are doing now, insurance companies, all of it, they're in it together. If a patient requires a Foley catheter to be inserted, what they do is, that first urine that we get, they send it off or whatever. If a person did not come in for signs and symptoms of a urinary tract infection, but they need that Foley catheter inserted for some other procedure or whatever reason that's not related to a urinary tract infection, what they're saying is that, we the nurse caused the urinary tract infection. And that is not the reason they came in. And what insurance companies are doing, they're not even paying for the care that's associated with that urinary tract infection. That facility has to incur those costs. So you're seeing that now. If the patient comes in for, I don't know, they have asthma, something wrong with their asthma or hypertensive crisis, and they end up with a broken hip, you're seeing facilities insurance companies not even paying for the care that's associated with that injury, because they're saying, well, we should have prevented, that client should have not fallen, because we always think about safety. We always want to think about preventing falls. Okay, so informed consent, we want to make sure that the client voluntarily agrees, and that's after an explanation has been given, and make sure that that's on their level, that they understand. A lot of times they'll have videos for people to watch. They will have multiple conversations, but nevertheless, informed consent is the voluntary agreement for treatment after an explanation has been given. We talked about practicing out of the scope. What else did we talk about? I'll give you another example. We started talking about the impaired nurse. And so if we saw the nurse, if the nurse is caught stealing narcotics, caught stealing, the patient's belongings for their own personal use, that is an example of a criminal act. So if they're using that for their own personal use, that is an example of a criminal act. And so, let's see, what else we talked about? We talked about what we call it whistleblowing or reporting, self-reporting. I think, forget what that slide had it worded, but you all were right. We want to report things to the supervisor. We want to, just report it, even if it's something that it is important. For example, if the nurse wrote down or documented that they went in and checked on a client asleep, they never moved from that desk. Not that we're spying on them, but if in the event that the nurse is documenting things that are not true, then we want to report that behavior to our nurse manager or our supervisor. Because in the event that something happens, they're going to come back in, gather information. Gathering that information, the cameras in these facilities work. They roll the camera back and they say, well, we did see her sitting there, but the other nurse was sitting chit-chatting with her too. They get statements, they roll cameras back. And so just make sure that you're reported, and then it's up to the manager or the supervisor to follow through, and then to make sure that, to investigate, just to see what's going on. Doesn't mean that sometimes people tell things that are not true, but nevertheless, it will be investigated and the findings will come out. So when we are talking about the nurse taking medications or documenting things that are not true, we I always want to think about the patients first. Ensure that the patients are safe, because we want to make sure that they're receiving the appropriate care that they're supposed to. We want to notify our supervisors. Some places they call them nursing supervisors, and they call them managers, but nevertheless, whoever's in charge, we want to make sure that they know. And then, of course, we're going to have to document. They're going to ask for statements for you to write it down and to actually document it. And then facilities, they do have, if it's related to substances, they do have procedures for reporting, that's suspected until proven that it is. So find out what that facility's procedure is for actually reporting that, so that you can, follow all, the appropriate things. But nevertheless, we're going to report that to our supervisor. Okay. All right, let's get back to our PowerPoint here. We talked about why we need the insurance. Okay, so we were talking about the 4 steps, the 4 parts of negligence. So here we go. Let me share my screen. All right, so those 4 elements are duty. Is this patient assigned to me? Am I performing the tasks that are written down for this person? Am I providing this individualized, this unique care for this person? Or if I am not, that's a breach of my duty. Did this person receive damages, injuries? And then if they did, can we relate it to us not doing what we're supposed to be doing for that client? So here it is again in different wording. So duty refers to the nurse's responsibility to provide care in an acceptable way. The nurse has a duty based on the education as well as the policies and standards of that place of employment. Breach of duty means that the nurse did not adhere to the nursing standard of care. What was expected of the nurse was not done, or was not done correctly. So we did something and we didn't do it correctly. Like the example that I gave, the patient needed 2 people. Initially, it was 2 people in, then one person left out, or we needed 2 people, and the nurse was like, "No, that's okay. No, that's okay. We don't need. I can just do this on my own." And what they're doing is they're bringing that expert nurse to establish the standard of care. They'll look at the Nurse Practice Act. They'll look at the facilities, policies, and procedures, and they'll bring in other nurses and say, "Hey, if you were in this situation, what would you have done? Was this a reasonable response?" And then damages mean that the client must be able to show that the nurse's negligent act injured him or her in some way. The client must prove the actual damage. They have to have some proof. X-ray reports, shows that the foot, the toe, the hip, whatever was broken. The lab report that shows, that this person has a urinary tract infection. Have to have some type of proof. Statements, camera footage. And the proximate cause means that a reasonable cause and effect relationship can be shown between the omission or commission of the nursing act and the harm to the client. Did the nurse's negligent act cause the injury that's in question? Is there a relationship? Because this didn't happen or because this did happen equals this injury this person actually has. Okay. Steps of bringing legal action by a client. So, of course, they seek the attorney's advice. The attorney will bring in that nurse expert to review the chart. Because sometimes when people have bad outcomes, it does not mean that healthcare professionals did not do what they were supposed to do. So they'll go in, the nurse expert will look at those standards of care, what's expected, the facilities, policies, procedures, and what the nurse documented. So always take that time to document. The complaint file, defendant response, depositions. These are statements that are taken. Discovery. This is where they pull the video footage. They'll get statements from other people, time logs, time clock, clock in and out for our break, were we on break, were we even there? Trials testimony, verdict rendered. What were the findings? What do they want to happen? All right, so let's do a knowledge check. Go back. Okay. The nurse caring for a client miscalculated the dose of medication and administered it to the client, who was successfully resuscitated. Which legal action can be taken against the nurse? So let you just think about it for a moment. Like, what happened? What should have happened? Is there a relation? Is it an expected outcome, or this is something unexpected? Is this just a bad outcome? It has nothing to do with what the nurse did. Okay. The nurse has committed an unintentional tort in which harm was not intended, because it says that they calculated, but it was a miscalculation. But the nurse did not maintain the standard of nursing care and did not do what a prudent nurse would do with comparable education and skills would have done in a similar situation. So when we're having because usually pharmacy calculates things for us, but if we have to calculate them on our own, how do you verify what you're calculating is correct? Get another nurse to calculate. You call pharmacy and say, "Hey, I'm calculating this. Is this the correct amount that I'm supposed to be administering?" Or we just go on and just minister what we think or we're our guess. So even if we verified it with another nurse and it still was the wrong dose, this patient had to be resuscitated. So it was an unintentional tort. And so even if pharmacy, you look at those packages and something doesn't look right, you want to always go back to pharmacy. What's going to happen is they're going to say, well, the nurse administered the medication, even though we did not package it. So if if it looks, you have that question, just take the time to verify what's in there and everything is correct. Especially if you have, you're hesitant about, the package and what it's actually saying versus your order. Call the healthcare provider. Now, what was that? Now, this order says this. I'm missing a component because they're going to say we administered, the nurse administered, so it falls back on us. Okay, we talked about privacy and confidentiality. Information that must be revealed, though, even though, we want to keep things private, these things must be revealed. There's a list. Each state has a list of reportable diseases on their state's website. Those are things that we have to report. Even if there are injuries, this person, the person knows how to use the equipment, but there was an injury related to that equipment, we still have to report it. Child or adult abuse or neglect, we must have to report it. Clear and present danger, criminal acts, unfortunately things happen while we have to report these things. So be vigilant when you go into your clinical sites and you decide to go work somewhere, be vigilant. Ask what is the safety plan, know what those safety plans are, which doors are locked, is there proper lighting. And I know a lot of facilities, your parking, you don't park up close to or near the entrances, especially for those of us, like if you work after hours, be thinking about what that looks like for you. A lot of facilities, they have, what do you call those? The policemen, they have security. Some facilities don't have police. They don't have security. And, but nevertheless, where they want you to park it is far off. The lighting isn't well. So there's a conversation that we want to have with our nurse managers. Hey, we need an alternate plan because when we come in at night or whatever time of day, it's not bright outside. The lighting is limited. Can we have an alternate place? Because harm is out there. It can happen. So a lot of facilities, some facilities at the shift change, they'll have a vehicle or something that will transport the staff to that distant parking lot. They make you park far, far away, which I'm sure you all have witnessed that going to the various sites. They want you to not park up close, but just be thinking about not only the patient's safety, but your safety as well. Clients' rights, the patient care partnership recommendation. So it's the patient that's receiving the care. So we really need to include and provide that individualized care. We need to include those things that they think are important. And as long as it's not causing them any harm, those things that they value, we can incorporate those things. Usually healthcare providers incorporate that into their care. We want to ensure that the environments are safe and clean. We want those patients involved in their own care. And then we start thinking about discharge on admission, even though things might change before they get discharged, about the different things that they might need. But we need to start thinking about, is this person going to need a skilled nursing facility? Will they need home health? Will they need a hospital bed? Will they need a cane, walker, and crutch? What resources will they need? Do they need Meals on Wheels? Do they need financial assistance? So these are things that we need to, the social worker, sometimes in some facilities, the case managers work along with the social workers and they help address all these different parts, because think about it. All these parts are part of this person living and having the best life. And so if they need those financial assistance, identify those programs that are out there that assist with medication costs and things like that. Some facilities have those. You routinely, you will be that nurse that have that team, but then they have these extra positions or these extra tasks that you can actually perform. So you'll ask those questions, during those interviews. We've talked about HIPAA, the client's privacy. When coordinating client care, the nurse will adhere to the minimum necessary rules to protect the client's privacy. So what is this? Minimum necessary. So for example, if we have a medical equipment company, they are trying to deliver a hospital bed to this patient. They're trying to deliver an oxygen concentrator, whatever it is to this patient. That medical equipment company only needs certain information. We only give them the minimum necessary information because we still have to protect this client's privacy. What is that information that they will need? The minimum information they'll need is the client's name, who they're going to give the equipment to, where they're taking it to, that's the address, and then how they're going to get paid for that, what they're actually taking to that patient. They don't need to know the medications they're on. They don't need to know their diagnosis. They don't need to know all this other stuff about the patient because that's infringing upon that client's privacy. HIPAA requires that all covered entities designate a privacy officer. Clients must be given the notice of private practice, and they'll send you these privacy notices. You get them every so often anyways. But they notify you that your things are held, your information private, and it's utmost important that we keep these things private. So client competency, we want to think about, is this patient 18 years or older? Is this person pregnant? Are they married? Are they a self-supporting minor? Are they competent in the eyes of the law? Or are they incompetent? What is it that are we providing care that's legal? And this is my little alarm that's going off to let me know you all. We have 1 minute. I'm going to pause here because we have 1 minute before you take your next break, which you all log off. And what I do is finish going over the material. I will say that don't forget, we do have our exam reviews coming up. Commit to, if you can attend them, commit to at least looking at the links that we provide. So go back to the announcement section and look at the dates and times. There are 3 of us, Dr. Tenza, Dr. Martinez, and myself. Look at those dates and times and also get your ID. Make sure you have your IDs because you will need to show that. Make sure you have your 2 devices, your chargers. We will send out where you can do the practice exam. So make sure you do that. Therefore, it ensures that your computer, meets the specifications of ExamSoft, and you'll get that practice exam more than likely for all of your classes. It's just a routine thing now, just to ensure on exam day that your computer is ready to go. Don't forget about that 72-hour prior notice if you are thinking that you need that exam proctored on campus. Don't forget, if you have accommodations, to send that out to each of your professors every term. And so, to be a good steward of your time, officially, we still have at 11 minutes to take our other break. So class is officially over for you. I'm going to stay on and finish reviewing some concepts. As soon as this downloads, I upload it. Make sure you go back through all the classroom recordings, you all attend live exam reviews, and at a minimum, look at the links. Have a good night and have a good week.
The live review is this week.
Yes, Dr. Tenzas is, I could pull it up here and real quick and look and see when it is. Hers is first. So in the announcements, it is under, it says that exam review schedule for the term. So for exam 1, Dr. Tenzas is actually tomorrow. Let me share my screen here. Hers is actually tomorrow. And then, you attend any or all, but at a minimum, just make sure that you're reviewing the links that we provide. So hers is tomorrow, 7 p.m. Eastern time.
Okay, and it looks like yours is
Thursday.
Oh, okay, Thursday at 6 p.m.
Eastern Standard Time, yes. And Miss Foster's is Wednesday. So Tuesday, Wednesday, and Thursday, yes.
Okay, and this is in our announcements, right?
Yes, it's in the announcement section under exam review schedule. And then
Gotcha.
you want to go there because you click our links. So for our links are already there too. So if you decide to go Dr. Tenza, it's there. You just click it and it takes you on into her Zoom.
Okay, cool.
Yes, and it
Thank
has it
you
for
so
each
much.
exam. You're welcome. Have a good night.
All right.
You all make sure you go back through the classroom recordings. Make sure you take the time to go back through those as well.
Okay.
I have a quick question. I thought we were supposed to do our groups today.
I'm gonna
Or
send it out to your email. It's not gonna be the email, it's gonna be in the announcement section. And I can send it to the email as well.
okay, that'll work.
Yes. All right. Are there any other questions, you all? Mackenzie, Nicole, you don't have any questions? Health Insurance Portability and Accountability Act. You want to be reminded about the client's privacy. HIPAA requires that all covered entities designate a privacy officer. So you, in whatever facility you go to work in, you may be that privacy officer. Clients must be given that notice of privacy practice, which provides information on how to contact the privacy officer and how to file a complaint in the event that they think that their privacy has been violated. So that would be like an additional task that you would have in a healthcare facility, but know that all facilities supposed to have a person that's designated a privacy officer. And that person educates and informs the patients of how to do the complaints and who to contact. So we want to keep in mind about, is a client competent? Are they of legal age? What constitutes them as being competent? Are they legally an emancipated minor? In the eyes of the law, can this person make a competent decision? In clinical, able to understand the problem, the options, and make a decision based on sound reason. Can this patient understand? Do they understand what's going on? Are they able to make decisions based on a sound reason? Okay. We have authorized, informed, and general implied consent. You go in at the patient, you say, well, hey, we're here to check your blood pressure. And that person sticks out their arm. They don't say, okay, you can check my blood pressure, but them extending an arm, it's kind of implied that you can go ahead and check that blood pressure. Nevertheless, we want to always explain procedures, and we want to explain things in the verbiage, the language that people can understand. If I speak German, that's whatever my first language is, that information should be provided in my first language. It should be easy to understand. It should not be in healthcare provider terms, because we are learning these terms, so that the way we speak in the terms that we use are not layman's terms. We will make sure that information is easy understandable to the client. To make an informed decision, the client must be told what the diagnosis, what the suspected diagnosis is. They need to know who is going to actually be doing the surgery, who's going to be putting them to sleep. What is the expected outcome? Are there any benefits? They need to know about those side effects and complications. They have to be given explanations of alternative treatments, the benefits of them, the possible side effects, the prognosis if the treatment is done, when known. They need to make sure that all that patients' questions have been answered. An explanation: the client has the right to revoke written permission at any time. That client can say, hey, I changed my mind. You can be rolling them down the hall to surgery. They have the right to revoke, to change their mind, to say, hey, I no longer want this done. I no longer give you permission to do this procedure. And it's okay. So we do have advanced directives. A living will not be used to specify who. A living will is not used to specify a person. Okay. A living will can be used to express treatments that the client does not wish to receive, such as being put on a ventilator and being provided comfort measures. A durable power of attorney is appropriate document to designate a healthcare proxy. A durable power of attorney does designate a person to make those decisions. A living will does not specify a person. And a durable power of attorney is valid in all states. Do not resuscitate order. Is an advance directive based on the Patient Self-Determination Act that gives the provider the legal permission to write the order. A patient has the right to say, do not resuscitate me. In the event that they are found without heart rate, pulse, respiration, and blood pressure, they have that right, and an order can be written. So end of life issues. Removal of life support systems. If a nurse removes a life support system before the healthcare provider pronounces the client dead, it can be considered an act of murder. We cannot turn off ventilators. We cannot disconnect tubings unless that healthcare provider pronounces that client deceased. Otherwise, it can be considered an act of murder. Okay. Physician-assisted suicide provides an assisted suicide physician provides the means for death. Organ donation is a voluntary act. The Good Samaritan Act, a person who renders emergency care in good faith at the scene of an accident is immune from civil liability for his or her action while providing that care. A nurse must use clinical judgment to interpret the patient's unique situation. So consider what is going on with that patient. For example, do they have a disease process going on? It could be heart failure, it could be diabetes. Consider that client's unique situation. Consider, do we need to do further assessment to ensure that we provide the safe care for that client? We want to consult that healthcare provider that allows us to provide that tailored approach and provide and to address specifically what is going on with that patient. We want to assess them further, and then we want to consult that healthcare provider. We want to let that healthcare provider know what is going on with that client. We want to gather vital signs. We want to, if a person is actively bleeding, we want to critically think, and it involves purposeful, evidence-based decision making, assessing the client's vital signs and the source of bleeding aligns with the nursing process and scientific principles, such as collecting and verifying data before acting. Okay? So critical thinking involves that purposeful, evidence-based decision making. You want to assess things, and it could be assessing the source of bleeding. It could be assess their glucose. We want to use that nursing process. We want to collect data and verify that data before acting, before taking action. Critical thinking involves tailored approaches based on the circumstances and the client's needs, as well as using problem-solving strategies to achieve the safe outcomes. So many times if we're in that client's home, we want that environment to be safe. We may have to adjust and adapt things, modify things so that client still have, so that they can be safe while they're moving around their home, because we want them to be as independent as possible. So we want to adapt whatever's in that household so that client can still move around with ease and with safety. We talked about priority. We want to consider, what outcomes do we expect for this client when we, airway, breathing, circulation. We want to consider those things. When we have clients that are newly diagnosed, for example, if they're diabetic or they're hypertensive, the more than likely that patient will be having to get their medications adjusted because they are newly diagnosed. So monitoring those blood glucose levels and also those blood pressure readings so that adjustments can be made to those medications. We also want to consider the learning style of our client. We want to make sure that information is put into terms that they understand, even if it indicates that we may have to bring someone else in. Sometimes there are videos, we have handouts, but nevertheless, make sure that we are addressing that preferred learning style. And then we can always use that teach-back method. That teach-back method that indicates that client is able to demonstrate verbally or actually demonstrate a procedure back to us. And therefore, we can best understand whether or not the information that we gave them, whether or not it was really understood or not. Okay? So standards-based approaches like algorithms are critical for ensuring safe, evidence-based decisions, especially in high-risk situations. So if our clients are having chest pain, if they're having diabetic crisis, those algorithms their structure and their support that guides our decision making in those emergency situations. And you'll see them. A lot of facilities will have them. A lot of people have them. They're specific to that setting and most of the emergencies that they are presented with. But we do want to know that those algorithms, they offer that guide, that structured guidance and support for us to help us in making decisions. What's the next steps? What's the next steps? They have, if the patient is yes or if it's no, those algorithms clearly identify what we should be doing next. We want to be aware of any changes, like I mentioned early on, of any changes, noticing any cues or any patterns that our patients, are displaying. So we know the RNs, they develop those nursing care plans independently, using all steps of the nursing process, including nursing diagnosis. So both the RNs and the LPNs can administer medications, okay, under the direction of a healthcare provider that has prescriptive authority. So not every healthcare professional have the authority to write prescriptions, okay? RNs are taught in-depth assessment skills, including comprehensive physical assessments of all body systems as part of their basic education. RNs have the authority to delegate tasks to the LPNs and unlicensed personnel. Both RNs and LPNs, we both collect patient data. The LPNs focuses on basic data collection, such as vital signs and therapeutic responses, while the RNs perform more comprehensive assessments. Okay, so LPNs can administer medications, they can collect basic patient data. While the RNs are developing those care plans, they can also administer medications. The RNs are performing those comprehensive health assessments. They can delegate tasks to the unlicensed personnel, and they can also collect basic patient data, basic and comprehensive. So let's think about the nursing process. What happens during that assessment phase? That's when the LPN collects and report data, but we do not make that nursing diagnosis when we don't do those initial assessments. So during the assessment phase of the nursing process, the LPN can collect and report objective and subjective data. Subjective data is what the patient has said, and objective is the information that we have collected using 4 of our 5 senses. Those things that we've seen, we heard, we touched, that wound may have an odor, those things that we have actually smelled. Okay. So assessment, we're collecting that data, the nursing process. Planning, we provide that input and help identify basic care needs. Interpretation, carrying out those interventions and report patient responses. And then evaluation, report patient's progress. Were the goals met? Does this patient still have a fever? Do they still have pain, or their pain has subsided? Report patient's progress and any changes to the registered nurse. We want to be respectful to our clients. We want to incorporate their cultural. We need to know about what their cultural values are, but we want to be safe and provide that effective care for our clients. And so if we have patients that are refusing medications based on what their cultural beliefs are, their cultural sensitivities, then we need to let a physician know about their refusals. The client has the right to refuse, but we still want to let the healthcare provider know that they are refusing their medications for whatever the reason is. It might be that they need to be offered alternatives, like the example that I gave early on. Instead of the medication, are there any non-pharmacologic agents, interventions that we can implement? Back rubs, a walk, music therapy, different things like that, instead of actually taking that medication. Cultural competence involves actively learning about and respecting the diverse values to provide that individualized care. We want to avoid making assumptions, and we do want to seek to understand our clients and their backgrounds and the things that they value. And as long as it's not causing them any harm or us any harm, we do want to incorporate that into their care. So the National Association of Licensed Practical Nurses Code of Ethics requires practical nurses to maintain patient confidentiality. We talked about violating HIPAA. We want to keep patients' information private and secure. We want to make sure that we are not speaking too loudly when we're at the nurse station. We want to make sure that we are disposing of information that has clients' information on in appropriate receptacles. Maintaining confidentiality is crucial. We want to protect that patient's privacy. We want to build that trust so that we can have that nurse-patient relationship. Sentinel events are defined by risk or occurrence of a serious harm and must trigger immediate institutional investigation. That's where they, see what was the root cause. A sentinel event, the patient, there's serious harm that has come to that patient, or that patient may even have died. That's what's called a sentinel event. Is an unexpected event that reaches the patients and results in death, permanent harm, or even severe temporary harm. And so after a sentinel event occurs, we have to see what the root cause is. So there's usually analysis, information is gathered, and we're trying to see what happened, because there's been some type of permanent damage to that patient, some type of permanent damage. So veracity is truth telling. So if something happens, and we tell the truth about what happened. Hopefully we've established that therapeutic relationship, and clients are more apt to not legitimize, because they, you're being honest with them. You're telling the truth about what happened, and you establish that relationship, that therapeutic relationship up front and initially. So autonomy, we talked about those ethical principles: autonomy, beneficence, non-malfeasance. Moral distress occurs when a nurse knows the ethically correct action, but feels powerless to act due to institutional or legal constraints. Be sure to have your ID, your 2 devices. Ensure that you have your chargers. Be sure to complete the practice exam to ensure that your computer meets the specifications. Make sure that you have that dry erase board or that clear sheet protector. You don't need a calculator because that's built inside. Remember the 72-hour prior notice. If you're thinking about getting an exam proctor on campus, be sure to send that email to myself, Dean Darlene Brown, and your campus dean, requiring that. If you have accommodations, make sure that you send that information to each professor each term.